Okay, so for those of you who don't know me, I'm Kennedy Ringelberg. I'm one of the Navy PGY4 orthopedic surgery residents, rotating here at Scripps, and today I'm going to be talking to you guys about cervical spondylotic myelopathy. I am sure that many of you present can teach me more than I can teach you on this topic, so feel free to stop me, ask any clarifying questions, or provide any comments as I go along. Cervical spondylotic myelopathy is defined as spinal cord dysfunction resulting from chronic non-traumatic compression, and it's cited as the most common cause of spinal cord dysfunction in adults. CSM most commonly is a result of degenerative processes, but also can include ligamentous etiologies like OPLL and OLF. It often presents in subtle ways and comes on insidiously, and we'll kind of get into all these symptoms in just a little bit. So it accounts for over half of non-traumatic spinal cord injury in North America. There's lots of studies out with multiple or varying prevalence estimated, but I should point out that it's often difficult to estimate the true incidence, and it's thought to be underestimated as many patients either go misdiagnosed or the diagnosis can be missed by providers. And I would say even more relevant is that patients often don't perceive these subtle changes in their function, or just attribute them to typical aging process, so don't necessarily seek medical attention. And then one thing to point out just with this last bullet is that surgery for cervical spondylotic myelopathy is increasing rapidly in the US. So myelopathy is a result of a cascade of events that leads to spinal cord compression and potentially repeated dynamic injury as well. Degeneration can result in central stenosis in many ways, including disc bulges and osteophyte formation, ligament buckling or hypertrophy. OPLL can contribute, as I mentioned before, and then instability can lead to, again, sort of repeated dynamic injury to the cord. One other thing to point out in terms of alignment is that loss of natural lordosis or even frank kyphosis can result in the cord being sort of draped over the anterior elements of the spine, resulting in more of a traction type injury. And then also should point out that congenital factors can increase risk of developing stenosis. So that's one thing to watch out for in patients and can also alter your sort of treatment strategy. Ultimately, static compression and again, potentially dynamic injury then result in direct axonal injury and is also thought to contribute to vascular ischemia, congestion, which leads to further axonal loss. The natural history of CSM has been well studied and characterized. It's typically thought to be periods of quiescence with stepwise decline in neurologic function. In this classic paper, Clark and Robinson found that patients typically followed three patterns of functional decline, and that included 75% demonstrated kind of this classic stepwise deterioration in function. About 20% demonstrated more of like a slow, steady progression of the disease. And then there were 5% or occasionally you can have a really rapid onset of symptoms, and then patients remain stable for a while. Other studies have kind of also described this gradual decrease in function, and all that is just to say that patients will ultimately decline in their function. It just kind of becomes a question of when, which is not well understood. And this plays a role in deciding how to treat these patients. And then I would just note that risk factors for deterioration include these things listed here. And if any of the patients that we're evaluating have any of these, then it may be a reason to get more aggressive with treatment. As always, diagnosis begins with a good history and exam. You want to delineate the timeline of pain and how long their symptoms have been present. Also important to evaluate the distribution of pain and any neurologic symptoms that may be associated. And this might include numbness and tingling. One thing to point out for CSM as opposed to like radiculopathy is that it won't necessarily follow a dermatomal pattern. And patients can present with bowel or bladder changes. They can also present with weakness. And again, it's typically a proximal to distal weakness pattern as opposed to radiculopathy is commonly the reverse. But important things to ask about and sort of more specific for spinal cord compression is difficulties with dexterity and fine motor movements, kind of a feeling of clumsiness in their hands. And patients may also have difficulty with balance and gait as well as coordination. Like I mentioned, you want to make note of how long these symptoms have been present, and then figure out how it's sort of affecting their life and what limitations that they have, because again, this will ultimately determine how aggressive you want to be in treating them. As far as exam goes, one thing to watch out for and pay special attention to is upper motor neuron signs, particularly in the upper extremities. And this includes the Hoffman reflex, which is pictured down here on the left, and then the inverted radial reflex, which is pictured on the right, as these are signs of spinal cord compression. And then other upper motor neuron signs in the lower extremities like Babinski's, clonus, and potentially hyperreflexia. Some other tests that have been described, again, more specifically for cervical myelopathy, is the grip release test. A patient should be able to basically clench and open a fist 20 times in 10 seconds. If they're not able to do that, it's indicative of intrinsic weakness and, again, maybe a sign of spinal cord compression. You also want to watch out for Lermit sign, and then tandem gait or Romberg can be used to assess their balance in the clinic. I should point out that none of these tests in and of themselves are all that specific for myelopathy, but should be kind of looked at as a constellation of clinical tests in conjunction with the appropriate history that may support your diagnosis. There's several classification systems that have been described for cervical myelopathy. The neurograde is relatively simple and is based on a patient's ambulatory function. But because it's sort of so simple, it's kind of quoted as being less sensitive to change over time, as these are relatively large jumps in functional decline that a patient may not get to throughout the course of their life. One other classification system that's widely used is the Japanese Orthopedic Association score, or typically we use here the modified JOA, which is just the JOA without a sensory assessment of the lower extremities and trunk. And also, because it was initially described in Japan, we swapped out using a spoon instead of ability to use chopsticks. It's thought to be much more sensitive to smaller changes, and I know that at least in the Navy, our providers get a JOA basically on anybody who comes into the clinic with neck complaints, and as they're following them serially, we'll have them repeat that test every time they come in just to get a sense of if they're declining or not. Imaging workup includes relatively standard X-ray MRI. These both provide anatomic details regarding alignment, instability on flexion and extension views, and then areas of neural compression, most importantly. Some measurements have been described that would be consistent with spinal cord compression, include transverse area of the cord, less than 40 millimeters squared, and then a compression ratio, which is described as basically the AP diameter at the site of maximal compression divided by the transverse diameter of the cord at the maximal site of compression. And a ratio of less than 0.4 is considered a poor prognostic indicator. CT can also be used and can further characterize osteophytes and other bony changes, as well as look for OPLL, which I mentioned before, as that may alter your treatment strategy. And also any sort of ankylosis or OPLL is important to keep in mind when determining your strategy, because it may inhibit you from doing any deformity correction if one is needed. Electrodiagnostic studies such as EMG and nerve conduction studies have also been described, but they aren't quite as widely used. So starting with conservative management for these patients, it's typically reserved for patients with either very mild symptoms or patients who have not had symptoms for very long, or those who have had, those who are very, very poor surgical candidates. If you do decide to pursue conservative measures initially, it's important that the patient understand the course of progression, and they should be well educated on the warning signs indicative of worsening function, and they should reach out to you if they have any concerns. It's reasonable to follow up these patients every 6 to 12 months to evaluate for deterioration. Just keep in mind that patients' disease, once again, may progress at a rate that's so slow that they may not perceive the differences. So it's important for us to be more active and keeping an eye on them and being able to judge them basically in snapshots to get a better idea of how their function is declining. This was one meta-analysis that looked at conservative treatment for CSM. They basically, again, found that conservative management was fine for patients with mild symptoms, but for those who had more severe symptoms, surgical treatment was associated with significantly better outcomes. As far as indications for pursuing surgery go, it could potentially be argued that everybody with this diagnosis meets operative indications. Again, just knowing the natural course is that these patients will decline. But it is a bit more complicated, and the decision should be shared with the patient based on their current severity of symptoms and functional deficits, as well as severity of spinal cord compression noted on imaging workup. Again, sort of just bringing to mind the measurements that I mentioned before, as they're associated with poor prognostic factors as it relates to conservative management. Patients who do well with surgery, which is something to keep in mind when counseling people, is patients who have milder symptoms, patients who are younger, and then patients who don't have as significant of spinal cord compression on imaging. And also, the more levels that are involved, the worse patients tend to do. Sort of the meat of this talk is actually talking more about surgical approach and strategies. Several have been described, but there's no sort of agreed upon consensus as to which one is the very best for cervical spondylotic myelopathy. Ultimately, the strategy is dictated by several factors, which includes the patient's anatomy, the number of levels involved, and any alignment or deformity, instability, and etiologies of compression. So the first decision to kind of make is whether to go anterior or posterior, and each has distinct advantages. Some advantages of going anterior is that you get direct compression of the cord from the anterior elements. It is sort of quoted as the best way to restore lordosis, typically associated with lower infection and less postoperative pain, and again is best for sort of reversing any kyphotic deformity that a patient may have. I do put an asterisk there because it has been described that if the kyphotic deformity is flexible and you're able to reduce them basically without doing any significant work or on like extension views, they can potentially just get a posterior fusion and that will be sufficient. Disadvantages of going anterior include higher complication rates when there's more levels involved, and then just be mindful and counsel patients on the specific complications associated with going anteriorly, like dysphagia and potentially vocal cord dysfunction. As far as going posterior, it's thought to be a little bit better when more levels are involved. It's typically quoted as being able to achieve a wider decompression. One major disadvantage is that you're, for the most part, relying on an indirect decompression of the cord, which requires dorsal drift of the cord away from the anterior elements, and we'll get to that in more detail in just a little bit. But it is associated with a higher infection rate, and it is thought to be more painful for patients as well. There have been multiple meta-analyses sort of comparing the surgical approach. The gist of it is that most of them basically have no major conclusions regarding which one is better, anterior, posterior. What's difficult again is it's a very complicated decision in terms of which way to go, and there are certain indications sort of for each. So these studies are, for the most part, retrospective in nature, and that in and of itself lends lots of selection bias in terms of how these providers treated patients, and then ultimately the conclusions we're able to draw based on them. But lots of these meta-analyses also sort of provide a framework for general guidelines in terms of which approach may be better in certain situations. And it is thought that, basically, kind of like the factors that I mentioned, if there's any deformity involved, the number of levels involved, the age of patients also plays a factor. This was one really powerful study that I thought I found. It was a randomized control trial comparing ventral versus dorsal approach for cervical spondylotic myelopathy, published in JAMA. All these patients had 2+ level disease from C3 to C7. They were neutral to lordotic, so that's an important point to point out, is that they had no kyphotic patients. Ultimately, they had 66 patients who were treated with a anterior approach, and then a total of approximately 100 patients who were treated posteriorly. What's one interesting thing to point out is that in the posterior approach group, it was up to the treating surgeon if they wanted to do a laminectomy and fusion versus laminoplasty. And then they performed subgroup analysis, delineating outcomes for these two groups. Their main points is that for the most part, there was no significant differences, but this functional score, the SF36 PCS, did improve more significantly for the laminoplasty group, and this trend persisted and remained significant 2 years after surgery. But it should be noted that basically all patients did improve after surgery, regardless of what approach that they had. The other important thing to point out is that they saw that patients who had anterior surgery had a much higher risk of complications overall. You can see that almost half of those patients had some kind of complication compared to posterior approaches. The laminectomy and fusion group had a 29% rate of complication, and laminoplasty only an 11% rate of complication. So again, it was sort of alluding to it, but there are lots of surgical options for treating cervical myelopathy, and this includes posterior laminectomy alone, potentially, posterior laminectomy and fusion. Going anteriorly, you can do ACDF, and laminoplasty has also been described and is growing in favor in the US. And there's also now, in the literature, arthroplasty is becoming a potential treatment strategy. And it should be noted that you can also combine these techniques. Again, lots of meta-analyses sort of trying to delineate which strategy is the most effective for treating myelopathy in these patients. But again, most of them have basically found that overall outcomes for patients are about the same, with no significant differences. But again, I should just point out that most of these are retrospective in nature, and that, again, lends itself to some selection bias in terms of how these patients were treated. But I think it's just important to, again, note the specific benefits of each and the specific complications that's associated with each when talking to patients. And they do point out in this review that all of these, again, are relatively low level of evidence studies that they used for analysis. I would say in general, ACDF and then a laminectomy with fusion probably remain the standard for surgical treatment of myelopathy. But as I mentioned, laminoplasty is becoming more popular in the US and was initially described in Japan. Some of the benefits include that it's motion preserving, so it's thought to be best for young patients, potentially patients with congenital stenosis, and also patients with multi-level disease. Contraindications include kyphotic deformity over 13 degrees, and then if there's any associated instability. So again, as I mentioned, if there's any kyphotic deformity, the cord is kind of draped over the anterior elements. So if you do a simple decompression posteriorly, the cord will still be draped over those anterior elements, and it won't relieve the pressure on the cord. So that's kind of the theory behind how this works, and why you can't do it with that certain deformity. I found a paper actually just published last year, which I thought was very interesting, and they looked at a lot of outcome measures when comparing laminectomy and fusion versus laminoplasty. All the patients had over 3 levels of disease. Laminectomy and fusion showed increased OR times, typically a greater number of levels involved in terms of the surgery, but that's just because they had to extend the fusion construct, usually 1 level above and below where they decompressed. They found no significant difference in post-op radiographic measures, but importantly, length of stay, risk of infection wound complication was lower with the laminoplasty group specifically. Again, I just think all this is to say laminoplasty is becoming more popular in the US and it's an effective treatment strategy. But again, with this retrospective study, the appropriate patient needs to be selected for this disease. And lastly, again, I mentioned cervical disc arthroplasty is potentially becoming a treatment option for cervical myelopathy. It's relatively new and there's not a whole lot of literature on it yet. But some arguments for it is that, again, it preserves motion and it reduces risk of adjacent segment disease. Granted, all of that data comes from patients who don't have cervical myelopathy, but patients who have cervical disc herniations, et cetera. Some arguments against arthroplasty is that, in theory, the ideal patient for disc arthroplasty has preserved disc space and facet joints, which by definition, these patients will not have. And also some surgeons would argue that the spinal cord probably benefits from the reduced motion that comes with a fusion to basically reduce the potential for dynamic repeated injury that these patients are thought to have. I did find one meta-analysis describing outcomes of cervical disc arthroplasty for CSM. This included 14 studies, 2 of which were randomized controlled trials. Basically, all patients demonstrated, again, improvements post-operatively. And there were 3 studies that directly compared arthroplasty versus ACDF. Important takeaways is that there was improved range of motion for the arthroplasty group and no increased rate of complication or revision. So basically just concluding that there is non-inferiority to ACDF. But again, these studies are small, limited follow-up, retrospective in nature, so there may be some selection bias. And also, we do not currently have the data to see how this sort of pans out long-term. There are lots of sort of workflows for how to decide on a treatment strategy for patients with cervical myelopathy. Again, I think the important things are just to point out that it's dictated by patient's anatomy, any deformity or instability that's present, number of levels involved will ultimately kind of determine your approach and strategy. In terms of outcomes following surgery, there are lots of basically poor prognostic indicators that have been identified. Cord signal changes are one thing that's specific. This study by Holly et al. Basically found that in elderly patients, there are no difference in outcomes between older patients and those younger than 65. But one thing that's important to point out is that complication rates go up exponentially once patients become elderly. There's a couple studies that basically demonstrate functionally, again, all patients tend to do better with surgery. And then, but all these are based on like functional scores. And ultimately, the surgical approach involved was not necessarily a significant factor. So main conclusions is that cervical spondylotic myelopathy can be present with subtle history and clinical findings and kind of require a high clinical index of suspicion, and also require us to follow these patients closely for neurologic decline, as it's characterized as a progressive neurologic disorder with periods of quiescence and stepwise decline. The decision for surgery, again, is complicated, should be shared with patients based on the degree of symptoms, functional deficits, and degree of cord compression. And then again, choice of surgical approach is dictated on a very individualized basis. I would say that there's not necessarily a single correct answer for each patient who undergoes surgery for this, but there definitely can be some wrong answers. And it's important for us as the treating providers to note when certain strategies are precluded. And these are my references, and I'm happy to answer any questions.
Okay. Well, it's just interesting. I feel like we always tell patients like the goal of surgery is to like prevent any further neurologic worsening, but there are studies that show there's probably some improvement. How do you kind of navigate, be cautiously optimistic, but also being like, look, like you may never get better.
I feel like it's one of those things where you kind of under promise and over deliver.
Yeah.
And that's like,
I feel like that's typically
that's been a home run. And,
Yeah, I mean, if everybody goes in thinking I'm going to get better.
Right. Yeah.
And it's not, they improve, they don't resolve.
Right.
That's a different thing too.
Yeah.
Just tempering there.
Yeah. Expectations.
Right.
But, yeah.
I have more of a technical question. I was reading about some people doing laminoplasties are actually skipping levels of where they plate, and they feel like that's causing a lot less pain, like substantially. Particularly current sting, I think it's going to publish on it, and that's like a bunch of outpatient stuff. But I was curious what you thought about that.
Skipping plate.
So, like for example, like
skip laminectomies.
no, he does. I think he does all his lamies, keeps it narrow, but he feels like doing that dissection, out laterally. If you just do it, skip levels, you preserve some more of that facet capsule, which allegedly can help with post-op neck pain in their experience.
Yeah, maybe. I
don't know if you.
I would find that hard to believe.
Yeah,
because you're not supposed to be taking down the capsules anyway.
Right. But I think inevitably when you're dissecting laterally, you probably get into it a little bit, even though we try not to. I think you inevitably.
Well, yeah, I don't disagree with that, but I find it hard to believe technically you can expose
Just
one,
Yeah, and skip. That's right.
Yeah.
and then another
It'd be interesting to see the video.
two levels down and
Yeah.
miss the one in between somehow.
So it's like for
Because at the end of the day, you're putting retractors in.
I don't know how
And
big yours.
So
C3 to C7, I think they were saying that
the one that makes a little more sense to me, although I haven't bitten off on it, is the laminectomy at 3 and then laminoplasty below. I think some people have moved to that.
Yeah.
I don't quite get that, other than technically it's C3 is a little challenging. The morphology is a little weird, and the plate I think could be a little close to the 2-3 joint or 3-4 joint. So that one I get a little more, but the skip thing, yeah, we'll see the science behind that.
Yeah.
Instead, I want to see that methodology.
In the setting of multi-level stenosis, and then there's one level where it's spondylolisthesis, and like the rest of the levels look
Static spondylolisthesis.
yeah, static maybe, but still compressed at that level. And then I was at AOS last year, and they were talking about like hybrid construct, laminoplasty and fusion.
Yeah, I've done that.
How is it technically different, or
I mean, it's not. I just have to do 2 surgeries.
yeah, okay.
But I think that's a great approach.
Mhm.
You got one level that needs to be stabilized.
Yeah.
Or you have to do foraminal decompression from the front. That's more ideal. Or they got a big anterior compromise of the cord and additional congenital narrowing. That I would say those circumstances are relatively rare, but definitely don't pigeonhole yourself into a single approach if you got 2 different issues that need to be addressed. The harder part there usually is timing. Do you need to do both at the same time? You roll the dice on one and hope that's enough, and then go back and do the other. And I've done that both ways, but don't be shy about doing both if you feel like that's the best choice.
How about like fusion at one level posteriorly, and then having laminoplasty levels surrounding?
Yeah, I mean, I've done that, but it's usually in the context of like cervical laminoplasty and then a T1-2 fusion.
Oh.
Yeah. Not like
In the middle.
in the middle of it. Yeah. Try to think where that would be meritorious. I mean, I guess if you had an instability, you could tackle it that way at a single level. But I'd be careful with those, because instability, at least my experience, is usually the facets are a big part of the problem. They become incompetent in their fortitude for handling lateral mass screws at a single level.
Yeah.
It's not
good.
I would be worried about the fixation.
Yeah, for sure. Makes sense.
So I think that you're not going to see that, practically speaking, very often, where you'd consider that.
Yeah, that makes sense. As they slip forward, the lateral masses
Well, why are they slipping forward? Usually. What happens? What's the disease process that allows a dynamic listhesis to occur?
sets being,
All three, right? Your discos and your facets become arthropathic,
yeah,
right?
yeah,
You're not usually slipping with competent facets.
yeah, yeah.
There's some disease process, usually arthropathic, that allows for
Makes sense.
anything else.
Can be spelled definitely wrong.
I noticed that.
That's something. Yeah.
That was nice.
I was,
One E away for perfection. Huh?
we're gonna go over our case, go over a lot of this.
Yeah, that's good timing, huh?
Yeah, yeah.
Cool. You need to change your talk.
Huh?
You need to change anything?
I don't think so.
All right.
But yeah, it's
Any other?
it's super interesting. Just, again, I came across a bunch of hybrid constructs and some papers that talk about like doing arthroplasty at some levels and like ACDF at others for multi-level disease.
Yeah, yeah. Yeah, I am a big fan of that being individualized.
Yeah.
By segment as to what you need, and then you go
Yeah.
back and say, what are my complication profiles for that
Right.
approach?
Yeah.
Am I going to do a front back approach, which adds complication
Mm-hmm.
profile? So you definitely have to go back to the complication side of things and cost.
Mm-hmm.
Some people don't have to pay any attention to that. Dan
Right.
just does what he wants.
But with cervical disc arthroplasties, how do you weigh or predict uncovertebral spondylosis causing a future issue? You know what I mean?
But it's hard. I mean, I don't think you know.
Right.
That's an unknown. We struggle with that, understanding patient disease and where that's headed, despite what we do.
Yeah.
I mean, that's why people often go on to fuse.
Use it right. Yeah.
Disc replacements.
He says 15%.
Yeah, that's the number, but I think it might be higher. That's the number in the trials. I think the blend of the FDA trials.
Right.
But if you go out into practice where we're applying it to much more spondylotic condition, I bet it's higher.
Yeah.
I bet it's higher. Be a good thing to study, huh?
I agree. I think it'd be higher.
Because you think about how those trials are really streamlined.
Yeah.
Disc herniations, very little spondylosis,
Right.
limited disc height loss, and then you get it into general use, and we're like, oh yeah, patients are demanding it.
Yeah.
Cedars puts them in everybody with a pulse, and right. And the good news is it probably doesn't affect outcome, but it's alarming for patients. They're like, wait a minute, I fused? Yeah, I wouldn't be surprised if it's higher, like 20%, maybe.
Yeah.
More.